Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith Rogers. Today, dentists and antibiotics. Liz Szabo is an investigative reporter with CIDRAP News. She joins Dr. Josh Sharfstein to talk about a recent series on the overuse of antibiotics by dentists. Let's listen.
Liz Szabo, thanks so much for joining me today. We're going to be talking about antibiotic use and dentists. How did you get interested in this topic?
I've covered antibiotic resistance for a number of years, but it's always been on the medical side. Late last year, I got an email from a gentleman who is fairly traumatized by the death of his mom due to C. diff, and it's likely she contracted the C. diff because of a dental antibiotic. She was prescribed clindamycin after getting a routine tooth extraction, and within days, she had some pretty awful symptoms.
Well, there's a lot to unpack there. So let's take a little bit of a step back, but then we'll get right into that story. Why have you been covering antibiotics for so many years?
Well, it's antibiotic resistance, according to experts, really poses a sort of existential threat. Antibiotics have been some of the most important technological and medical breakthroughs, and they allowed people to not only survive infections, to not die because you prick your arm on a rose bush while gardening, but they've also allowed people to get through surgeries and have cancer therapies and cancer treatments where it really put you at risk. So if our antibiotics stop working, a lot of our other medical interventions could fall apart. It can easily sound sort of apocalyptic.
Yeah, and what you're talking about is resistance, so that if you use antibiotics too much, then the microorganisms might adapt and suddenly the antibiotics don't work anymore.
That's right.
You're also talking about side effects from the antibiotics if they're not absolutely necessary. Is that right?
Yeah. What happened with this particular woman is she developed this infection called C. difficile. And what antibiotics do is they kill bacteria, of course, but sometimes they can kill the good bacteria along with the bad bacteria. So the good bacteria sort of help keep everything in check in your body. And if those get taken out, then the really bad bacteria can proliferate and overgrow. And my understanding is that's what happens with C. diff. So when she took this one antibiotic that's apparently notorious for being linked to C. diff, the bad bacteria, the C. difficile bacteria in her gut sort of grew out of control and they released toxins and she just got incredibly sick.
So you've been covering these issues for a while. You get a message from someone whose mom got very sick and died as a result, it appears, of antibiotics used in dentistry. So that set off a little bit of a light bulb for you?
It did. You know, I knew that clindamycin had a black box warning, and it has had a black box warning for more than 4 decades. So the risks are not new. And the gentleman and I were both wondering, gosh, I wonder why this is still being used. And I realized, this is kind of a different take. There's been an enormous amount of talk within the medical community and by health journalists about antibiotic resistance and stewardship in medicine, but I couldn't remember any other coverage in dentistry. So I looked into it and I found that dentists actually prescribe about 10% of all antibiotics. So it's a significant fraction, and I thought it would be great just to sort of take his questions and answer them in the story and just peel back the onion by answering his questions.
And what questions did he have?
Well, he wanted to know why his mom was prescribed this antibiotic and why it was clindamycin and why dentists are still using clindamycin given its really high risk profile. So I just sort of walked readers through that and then got into the issue of why do dentists use so many antibiotics in the first place, whether it's clindamycin or something else.
And now the mouth is notoriously a dirty place. There are a lot of bacteria in there. Traditionally, penicillin is the antibiotic most used for oral infections. But if people are allergic, dentists may turn to other antibiotics that have more side effects, like clindamycin. What did you learn about how dentists use antibiotics as they're doing different procedures in the mouth?
I think a lot of us, anyone who's ever had a wisdom tooth out has probably gotten an antibiotic. And most of the time, I think 85% of dental antibiotics are prescribed for prevention. So it's not that you have this terrible toothache and you're in agony and you need an antibiotic, or it's not even that you have a root canal and, before the root canal, they would give it to you. They're really seen as preventive or prophylactic. And of that 85%, 80% of those have been deemed to be inappropriate. And it was an impressive study because most dental studies are published in dental publications and dental journals. This study was so striking and important, it was actually in a JAMA journal. So, signaling that this is something everyone needs to know about, that 80% of these preventive antibiotics are not needed.
So most of the antibiotics are preventive, and most of the preventive antibiotics may not be needed.
Right.
And what that is doing, in other words, is exposing patients to the risk of side effects, but more broadly, potentially exposing all of us to a greater risk of resistant organisms.
Yeah, that's right.
How much does the dental community recognize about this problem?
I think the leadership in dental schools recognizes the problem, and the medical societies have put out some guidelines over the years. For example, the American Dental Association put out guidelines 7 years ago saying that if someone has tooth pain or swelling, the vast majority of those people don't need antibiotics. That the only time, if someone's got a really bad tooth infection, as I did a couple of years ago, you get them in right away and do a root canal or a tooth extraction, and that solves the problem. You treat the tooth and there's no more source of infection. So the dental societies say you only really need antibiotics in that circumstance if someone has evidence that the bacteria has spread around the body and become systemic, like you have a fever or chills. So they put those guidelines out quite a while ago, but they haven't maybe had as much of an effect as the society wanted.
And I'm sure there's always room for very specific examples or exceptions for people who might have unusual conditions, like issues with their heart valves, for example. But you're talking about sort of the general recommendation, is that right?
Yeah, that's a general recommendation. And I should say this is for people who have healthy immune systems. People who are immunocompromised are always special cases. But what I learned in this study is that about 50% of dental antibiotic prescriptions are written because of tooth extractions, like my wisdom tooth extraction, or a dental implant, and yet there are no official guidelines to dentists about how to use antibiotics in those circumstances. So this poor woman that I wrote about, she was a very beloved matriarch of an enormous family of grandchildren and great-grandchildren. She was prescribed an antibiotic after a tooth extraction. So if there had been guidelines for that, maybe she would have had a better outcome. But the profession is working to create those guidelines, but they're not out yet.
So solution one, guidelines, which are being developed. What else is on your list of things that should be done differently?
Yeah. Well, the interesting thing that we found is that in spite of, these guidelines first being put out there in 2019, 7 years ago, dental antibiotic prescribing has not gone down at all. It's actually gone up 6%. We were able to get exclusive data from IQVIA Institute, and it showed that from 2020 to 2025, the total number of antibiotic prescriptions actually went up 6%. And I was really happy to get this updated data because we're often happy if we can scoop other journalists in the newsroom, but I feel like I might have scooped academia because there have been no published journals, no published reports in medical journals that have data from 2023, 24, 25. So this is really up-to-the-minute data that shows that in spite of all these efforts, the antibiotic prescription issue is maybe just getting worse.
So what do we do?
Well, I talked to some really bright people at the Association for Dental Safety who think a lot about this. And they actually compared the antibiotic and antimicrobial resistance issue to the opioid crisis because both of these they're both public health crises, and they're both really serious. They can both affect individuals and the health of a whole community. And they also, unfortunately, have both been fueled by prescriptions, by well-meaning healthcare providers who think they're doing the right thing, providing a legal prescription. So people have looked at policy measures that helped the opioid a prescribing issue. For example, every state in the country, all 50 states and DC, have something called a prescription data monitoring program. And what they do is every time someone prescribes an opioid, it goes into a big database. So you can't shop from doctor to doctor to doctor getting a different Vicodin prescription at every doctor's. That's really helped people prevent overprescribing. And the other thing that states have done is that Congress actually got on this and passed a law requiring that anyone with a DEA license, a Drug Enforcement Agency license to prescribe narcotics, has to take an 8-hour course in opioid prescribing. So that's whether you're a doctor or a dentist or anyone. And people have said, you could use those same solutions in dentistry. Right now, dentists are required to take a continuing medical education periodically in order to renew their state medical licenses. But there's no requirement about what they take. They could take anything. They could take something about anesthesia or the latest trend in dental procedures.
How to make dental procedures less painful, just as an example.
Yes, pain control. But they don't, and there are antibiotic stewardship classes available, but dentists tend to overlook them. And one person who goes around the country lecturing about this said dentists think, oh, I learned how to prescribe antibiotics in dental school maybe 10, 20, 30 years ago. Like, oh, I want to learn something new. I want to learn about this new procedure that all the other dentists are doing. So they may not realize that there have been updates. So there's some people who think that state lawmakers could get involved by passing legislation to tell state dental boards of dentistry, listen, people have to take at least X amount of antibiotic stewardship education.
Yeah, I definitely see the logic. I think the evidence for how much that's contributed on opioids is probably not that strong, but I definitely see the logic. What about the Prescription Drug Monitoring Board? How does it help for dentists to enter in that they've prescribed antibiotics, say, for a patient?
Yeah, well, that's one approach. One thing I learned in this study is that when you have a patient record and a medical record, I think we're used to having that be accessible to all your doctors in your community, but it's not available to dentists because it turns out dentists and doctors and hospitals use different medical record systems and they don't talk to each other. So a dentist would have no way to know if you have like a prior history of C. difficile, which is a very big risk factor for getting it again, just from looking at your dental record. They're relying on you and your memory to think that it's relevant. They also don't know what antibiotics you've taken in the past. So a medical doctor may have prescribed a certain antibiotic, and if the dentist gives that same antibiotic, there's an increased risk of resistance. So a lot of doctors have said, and some dentists have said, it would be really great to know what the other care providers are doing. So, if there were some way to get everybody to shift to some common information sharing platform, I think people would agree to that. As long as it's, although I know people don't like change and people don't like spending extra money on things, but the PDMP approach, the state database, what would be one way for people to check in there and say, okay, before I prescribe you this antibiotic, let's see how many other antibiotics you've taken, and maybe I should rethink giving you this prescription.
Interesting. Well, change isn't easy. I think you're right about that. But there needs to be a good reason to do it. And your reporting really helps shine light on the need for change. Liz, I have one final question for you. Any advice for consumers if they're headed in, say, for a tooth extraction?
Yeah, sure. We tried to really simplify it in our article because we know that the average person isn't going to read these guidelines. But basically, at any time someone wants to prescribe you an antibiotic, maybe take a beat and ask them, is it really necessary? If your dentist wants to prescribe you clindamycin specifically, you could actually ask for a different antibiotic. That's the advice from the experts I talked to. Talk to them about what your allergies are and maybe look into finding out if you are as allergic as you think. A lot of patients, 10% of people, have a reported penicillin allergy on their chart. And if you can't take penicillin or a related drug in the same family, dentists will give you their second choice or their third choice. But the second and third choice antibiotics are not necessarily as safe or effective. And it turns out that although 10% of us think we have a penicillin allergy, fewer than 1% of us actually do. So the vast majority of the people listening to this, if you think you have a penicillin allergy, there's like a 90% chance that you don't. So one dentist said that, really the best thing to do would be to see an allergist and get an official test. Because if you do have the allergy, that's great. We'll keep that in the chart. But if you don't have the allergy, try to get that information out of your chart. Talk to your doctor and dentist so that way they can give you the most effective antibiotic and not a second choice antibiotic.
People shouldn't decide they don't have an allergy on their own, but they can go to an allergist.
Absolutely, because penicillin allergies can be life-threatening. So you should definitely not do this on your own, and you shouldn't hide your allergies or think, oh, I probably don't have it, I won't mention it. Mention everything you think could be a concern, and your dentist may not want to get you allergy tested right now because you have this crazy infection and he needs to do the root canal right now. But think about it maybe if you do have it on your future, not just for dentistry, but for medicine too, to think, is this a real allergy? I was surprised that 80% of people who had real penicillin allergies actually outgrow them within 10 years. You just stop being allergic. So even if you had a true allergy when you were 20, now that you're 30, you may not be allergic anymore.
Thank you for your work, and thanks for joining me on Public Health on Call.
Thanks for your interest.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.